Hello, good afternoon, everyone. I'm Mary Beth Marsden, and thanks so much for joining us live right now for GBMC's Ask the Oncology Expert. Today, we are spending the next half hour talking with Dr. Farzad Masroor. He is a head and neck surgeon with GBMC, and he joins us to talk a lot about head and neck cancer because this is World Voice Day and Voice Health Day, and obviously that is all affected when we're talking about the head and the neck and issues involving that. Dr. Masroor, thank you so much for being with us.
Thank you for having me.
We were talking just a little bit before we started this conversation about the broadness of your field, really. And when I heard head and neck cancers, I thought, well, what does that include? Can you sort of just walk us through a little bit of the main issues that people have from the part that you cover down to where the clavicle, you said?
Yeah, I can for sure. So it's kind of a funny term, head and neck surgery or head and neck cancer, because it's not really very specific. This area is quite broad, the head and neck area. But classically, the understanding or the definition of our field is that it's problems of the head and neck going from the skull base, so just below the brain, excluding the brain, and going down to the clavicles, excluding the eyes, and for the most part, not dealing much with spinal issues as well. So you can imagine that cancer anywhere in this area can be either skin cancer, it can be thyroid cancer, it can be salivary gland cancers, or it can be cancer of what I call, and what we all call, the upper aerodigestive tract, meaning that cancers of the mouth, the throat, the voice box, and the upper esophagus.
It seems to me, as a surgeon, you have to know a lot about a lot of areas.
It's true.
So, and this could include any kind of oral cancer, throat cancer, and we've been talking a lot about the voice today, so anything on your vocal cords, right?
Correct, yes.
So we have a lot of people who are tuning in right now because they are particularly interested in your field, which before we continue to their specific questions, and I want to get to every single one of them, I just want to talk about your practice and the multidisciplinary nature of it.
Yeah, so my practice, I like to emphasize that I am not a private practice. I actually exist within a center called the Milton J. Dance Jr. Head and Neck Center at GBMC, and we are a center that comprises many health professionals, not just a surgeon and my partner is Dr. Blanco, not just us, but we also have within our facility speech pathologists who are dedicated to problems of the head and neck area, particularly patients who are undergoing treatment or have suffered complications from treatment in the head and neck. We also have dedicated dietitians who are trained in optimizing nutrition and getting patients not only prepared for treatment, but also recovering from treatment and living their best lives afterwards. We also have social workers who are skilled in treating and helping out patients with head and neck issues. And so there's a whole team there, and so my practice exists within this team, and it's all built to really give the best care to the head and neck patient.
And when people come to you just having some symptoms, what kind of symptoms might they be having for any of these issues that would lead them to think they have a problem that needs to be looked into?
It's a good question. I would say there are some, my experience so far, some patients are coming in, they are referring themselves, and that they have some concern that there may be something wrong with them. I have some patients come in where they have a neck mass, and it feels abnormal there, and they have something they can feel in their neck, and they're rightfully worried that it may be cancer. We have some patients who feel like there's a problem in their throat, something stuck in their throat, and we evaluate that as well. But a lot of patients are coming in referred because their doctor has acted on a patient concern and picked up something abnormal. So, for example, if it's skin cancer, they'll find something on the skin and the head and neck that appears abnormal, meaning that it's and maybe an ulcerative lesion that has not fully healed, has been there for some time. There may be some bleeding, unusual amount of bleeding, or an area of the skin that just doesn't heal. Oftentimes, too, one of their doctors or their dermatologist has done a biopsy of it and confirmed that it is a type of skin cancer. Now, there's so many issues in the head and neck. So I'll go briefly about some of the things that I see patients for. We'll see some patients who have thyroid nodules that appear abnormal on an imaging test. And that thyroid nodule was not even causing any problems, but it was discovered incidentally on another test done for another reason. And that nodule is then biopsied and found to be something like a cancer that needs to be treated. Other issues we see are people with sores or pain in the mouth that have not healed, and that is very concerning for cancer too. And then throat issues like throat pain, changes in their voice, pain when they swallow. All these things, unfortunately, can be harbingers of something happening like cancer.
When you're talking about the mouth too, the dentist obviously can be sort of the first line of defense or the first person to see something too.
Absolutely, and they do a good job of it. And a large percentage of our population, of our patients that we see, are coming through that route.
So once we go through the process of trying to determine if there's something cancerous happening or there's a reason for surgery, these days, how is surgery done? Is it obviously as minimally invasive as possible, but are you able to do amazing things with lasers, or how is that working in that area?
In the mouth, we do, our goal is to, number one, our goal is to, if there's a cancer there, we have to remove it in an oncologically safe manner, meaning the first goal of our treatment is to get rid of the cancer. With that being said, our secondary goals are to make sure that the patient's form and function is optimized. So we can do that through things like reconstructive surgery, where we take tissue from one part of the body and bring it into the mouth, especially if there's a big defect there. Or we can rebuild the mandible that oftentimes, unfortunately, has to be removed for cancer or any kind of bony structure. We can do nerve repairs. We can do many things to restore form and function to the patient. And when you go further back into the throat or into the voice box, then we start to use some technologies that are very helpful. So for example, in the tonsil area in the back of the throat is an area we call oropharynx. And we're seeing a lot of patients these days who have oropharyngeal cancer that is related to HPV, the human papillomavirus. And these patients tend to be younger and tend to be otherwise healthy. And we find that these patients undergoing traditional treatments may have some long-term side effects that we would like to avoid. So for example, there is a new technology, it's called robotic surgery or transoral robotic surgery called TORS. And that is using a robot that we control, and it has slender arms, and we can get into areas and remove cancers that otherwise historically would require some major surgery to remove.
Are there some cancers that can be treated with just chemotherapy or radiation or both and not have to rely on surgery?
There are many cancers like that.
Okay.
So for example, oropharyngeal cancer is a type of cancer that we do carefully select these patients to undergo chemotherapy and radiation as opposed to surgery. And always the balance is you're trying to maximize your ability to cure the cancer while at the same time not cause too many side effects. And depending on how big the cancer is, where it is, then we go through our various treatment options, surgery being one of them, radiation being another, and sometimes we have to use both.
You mentioned the type of cancer that's caused by HPV, and I'm guessing you're hoping that number goes down with the advent of the vaccine, right?
Absolutely.
Yeah.
It's something that we've seen a lot more in the last 20 years or so, and it's become quite an issue, especially for patients who may not otherwise have traditional risk factors like smoking or alcohol drinking. And I do hope that in the next 30 years or so, as we get the vaccination program up and going, that we'll see less of these cancers.
I definitely want to get a lot of these questions in for people who are particularly interested. One is, what is the difference between a modified radical neck and a radical neck surgery for cancer? I am a throat cancer survivor, and will I have, okay, these are two different questions. Let's get the first one. What's the difference between a modified radical neck and a radical neck surgery for cancer?
Okay, so just taking one step back on that, So the question asks the difference between modified radical and radical neck dissection. But a neck dissection is typically done to remove the lymph nodes in the side of the neck, which are draining a cancer from somewhere else. It's basically a drainage basin that catches cancer as it spreads. So cancers of the head and neck typically spread in a stepwise fashion. First, they go to the lymph nodes in the neck, and then from there, they can go to other parts in the body. So the neck dissection is done to serve two purposes. One is to remove any cancer that may be there, but two is to accurately know what is the status of the neck, because that plays an important role in terms of the prognosis of the patient. Now, the difference between a radical and modified radical neck dissection is based on what structures are removed. And historically, all neck dissections were done in a radical way, whereby the large muscle we have here called the sternocleidomastoid muscle, that is removed, the internal jugular vein is removed, and a nerve that helps control your shoulder, your trapezius muscle, called the spinal accessory nerve, that is removed as well. Now, historically, doctors thought that removing all these things were necessary to ensure that you've adequately cleared all the possible tissue that has become involved with cancer. Now, in the last 20, 30 years, we've kind of moved away from that. We only do that if absolutely necessary, meaning that there's a tumor in the neck that has occupied those structures. But nowadays, we try to preserve as many structures as possible, and that gives rise to the term of modified radical neck dissection. So a modified radical neck dissection is when you do not remove, or you remove part of those structures or none at all. And if none of the structures are removed, then we have something that's even termed a selective neck dissection, where all the structures are spared and we're just removing the nodal tissue that is of interest to us.
We had someone who obviously is a throat cancer survivor and wants to know, will I have dry mouth forever?
It depends on, so a lot of times, unfortunately, we do see a lot of patients who have dry mouth after radiation treatment and even surgery as well. And the reason why is that the salivary gland tissue that is responsible for producing saliva has been affected by the treatment. And the short answer is, unfortunately, the dry mouth does not get better with time. And that's, one of the things that a lot of our patients tell us that is a significant impact on their quality of life.
What can be done? Because we have another question that's very similar, wanted to know, how can I increase the amount of saliva that I have?
So I think the first thing that can be done is, one is that, when you plan treatment, you try to do that in a way whereby salivary gland tissue is avoided. So for example, there was a procedure that was done here, and we still do, but it was done quite a bit in my predecessors, Dr. Califano, Dr. Ha, who were here, 5-10 years before I got here. But they would do something often called a salivary gland transfer, whereby one of the glands that produces saliva in your neck is transposed out of the way of a potential radiation field. So it's taken either to over here or up into the face, and then is spared the effects of radiation. And the benefit of that is that the patients we see afterwards who've had that procedure done, they still get a good amount of saliva in their mouth. Now, a lot of these folks who are asking these questions, it looks like they've already gone through treatment. So we can't go back and change what's happened, but we can, do other things that could potentially help. So there are many products that are artificial saliva products in the market, like Biotene and such, and patients sometimes feel like it does help. There are some medications that may help too, and these are medications that are designed to stimulate saliva production. One is called pilocarpine. Another one I think is called Exovac. These medications can have side effects as well in terms of particularly, you can imagine you take a pill, it's going to stimulate everything in your body that is related to that biochemical pathway. So you can get, your heart rate may change and such. So none of these measures, unfortunately, if these measures were very effective, then I would not be seeing many patients complaining of this, but I don't think they're that effective, to be honest.
So for the person who is struggling with the amount of saliva they have in their mouths, how do they eat? Do they have to drink? I mean, what's the procedure for them in order to kind of still be able to eat is it you have to drink water with every bite? I mean, how does this all work?
They basically, most of my patients who struggle with this, they're carrying around water bottles with them all the time, and they're drinking water all the time to stay, moisturized in their mouth. And also with eating, that's a good point. They have to make sure that they drink a lot of water to make sure their food is adequately lubricated, so they can eat and swallow effectively.
Another person asked, has said, I have had base tongue cancer. Treatment was radiation chemotherapy, but no surgery. It happened 2 years ago. I still do not have taste for food, and my mouth hurts when I eat some fruits like oranges. Is there any chance that I will acquire taste of food and will not have such a sensitive mouth in time?
So one is I feel bad for this patient. I feel like, this patient obviously, taste is so important to us. Eating is one of the, most important ways to enjoy life. If you can't appreciate food very well, then your quality of life definitely goes down. A lot of patients undergoing radiation treatment like this patient did, and they do get some changes in their taste during the treatment process, and it lingers on after treatment as well. Now that he is 2 years out, I think that unfortunately a lot of the benefit that he may potentially get, or a lot of the reversal of the change, the changes in taste he's having, is not as likely to happen. That being said, nobody has a crystal ball, and in medicine things are not black and white. I've seen many patients over the years where I think absolutely one thing is going to happen, and they actually end up doing a lot better. So I think not giving up hope and working with your healthcare providers, and hopefully things will get better for him or her.
This is a question about a laryngectomy tube, and I guess you'll probably have to explain what that is, but someone wants to know, is there any way to decrease the amount of mucus that collects in is it laryngectomy tube? Am I saying that correctly?
We say like a laryngectomy tube.
Laryngectomy.
Yeah.
So what is that? And obviously this person's having a hard time with mucus collecting in it.
So a laryngectomy tube is placed usually after a laryngectomy. So a laryngectomy is done for advanced cancers of the voice box, whereby we know that removing the whole voice box with surgery gives the patient a better chance at survival. So oftentimes we do this for very large tumors that radiation and chemotherapy will not help, or we do it for tumors that have come back after radiation and chemotherapy. Now, when you remove the voice box, you've essentially separated the communication between your nose and mouth and your windpipe. And you've now rerouted it to a permanent hole in the neck and separated it from your swallowing apparatus as well. It's a surgery that really changes patients' lives, and it's done, again, because we feel like we know that it will give the patient the best chance at living. Now, a laryngectomy tube is a tube that is oftentimes placed in their, what we call a laryngectomy stoma, in their neck through which they breathe, for a couple of reasons. One is you can outfit it with what we call an HME, which is a moisture humidification device, which actually can help this patient's complaints of having too much mucus. So the mucus oftentimes happens, and complaints around their stoma happens because they're breathing in air that is no longer humidified through their nose, because the connection is now disconnected. So if you put this humidification device on the laryngectomy tube, the air they're breathing in now is humidified, and it should be much more tolerable and pleasant to their windpipe and their lungs, and less likely to irritate things. So if that patient is not doing that, then that's something to definitely do.
Another question, can speech therapy help with tongue atrophy? Atrophy started 5 years after surgery and radiation.
Speech therapy absolutely can help that problem. You can imagine speech therapists are, this is their profession. They're designed, they are trained to really understand what's happening, the reason why their tongue is atrophied, but also to develop tips and tricks to best combat any sort of atrophy that's happening and to optimize their speech. So absolutely, that's something that I think if I were that patient, I would definitely pursue.
My soft palate seems a bit floppy or too big over the last year. It interferes with my voice, especially if I'm sitting. I have no breathing problems, but there seems to be a slight hesitation when I swallow. It's always more comfortable when I lower my chin. Should I start with an endoscopy to figure out what's going on?
The first thing to do, I think, seeing a professional who has expertise in this area. So ENT doctor would be a good place to start. So having a long, soft palate, we see that's very common, and having a long uvula is very common. And in fact, patients who snore, who have snoring issues or sleep apnea issues, oftentimes have long, soft palates. And you can imagine that these soft palate and the uvula, which hangs in the back of the throat, is an important area of creating resistance to air as you breathe it in. So if that area has a lot of resistance for whatever reason, and then requires a lot of air to get through, it can sort of irritate the soft palate and uvula, and almost like in a vicious cycle, cause those tissues to get bigger too. So having an ENT doctor check that out, maybe evaluating this patient for snoring or sleep sleep apnea related issues, those are good first steps.
Kind of along the same lines, do you find that there are people who, particularly when they're aging, find themselves aspirating more? They don't swallow the same as they used to. Is that increasingly an issue for people?
It is, yeah. As we get older, the swallowing is such an intricate dance between all these muscles. It requires a good, you have to be mentally very awake. You have to make sure your muscles are in good condition. All these comorbidities we have, those all play a role as well. And as we get older and as we have issues, then the aspirating can become more of an issue.
And so I guess if you are having an issue, would an ENT be your first kind of person to call as well?
I think it's a good place to start.
Okay.
I always think, also starting with your primary care can be helpful too. The head and neck is kind of an intersection of many different specialties. So, for example, if you have some patients I've treated before in the past, for example, I can remember a case of a man who was complaining of having some difficulties eating for some time. And unfortunately, he was sort of bouncing around between many different doctors. But ultimately, what was noted was that he was losing weight, which is always abnormal if you're losing weight in an unexpected way. But the thing that really struck out to me was that he had in his tongue had atrophied a lot, and in an otherwise healthy man, and this tongue showed evidence of being deinnervated. The nerve endings in it were sort of not working as much anymore. And my suspicion was that he had Lou Gehrig's disease or ALS, and that ended up being true, unfortunately. For example, if you're having swallowing issues, if you're having a lot of issues in the rest of your body, a primary care doctor oftentimes is a good person to sort of put the whole picture together, and oftentimes get other specialists involved who can help get to the root cause of the problem.
Someone writing to us right now says, thank you so much for your answers so far. This person says, I had a hemithyroidectomy, if I pronounce that correctly, 4 years ago without being on thyroid replacement medicine. Is there a chance that I may need to be on a low dose? Fatigue has been an issue. The labs all say I'm fine, but I think it's thyroid related.
It is possible. Most patients who get half their thyroid removed, they do not immediately need to be on thyroid hormone replacement. And that is because the other half typically picks up the slack. Now, thyroid problems are very common. Autoimmune issues affecting the thyroid. There are many patients who have their entire thyroid gland there, but it's just not working well, and they need to be on thyroid hormone replacement. So I would say that it is possible that over the years, your remaining thyroid lobe may not function adequately enough to give you enough thyroid hormone. Now, that being said, it seems like you've had your thyroid hormone levels checked and they were normal. So I would say the chance that it is your thyroid then is less likely. Now, you can get an expanded sort of thyroid hormone panel check to see if there's anything subclinical, like subclinical hypothyroidism happening. But that's something that you'd have to talk with your doctor about.
Do the numbers always tell the story? I mean, is there a downside to trying to treat it as though it were the thyroid to see if you felt better?
Well, I think the numbers are pretty good normally, and
Mm.
if you do take some low dose thyroid hormone, even though you are not hypothyroid, and you basically put yourself in a somewhat of a hyperthyroid state, that will be bad for you in the long term in terms of having too much. If you're in a hypermetabolic drive, it has effects on your heart. It has effects on your muscle mass. It has effects on your bone health. So all having too much metabolism or too much thyroid hormone is not a good thing for you long term.
Another question. I suffer from head pain mostly around my skull. Sometimes it goes to my forehead, but not often. Lots of times I wake up in the morning with this, and it can last all day or longer. What could be causing this? I had my head x-rayed or scanned, and it looked normal. There's a lot. I'm sure you have a lot of questions about this question, but
Yeah.
let me just put it this way. If this person is not getting the answers after an initial scan, what can they do next if they're still suffering?
So I think the fact that if this patient is older and these headaches are new, then I would be worried. Like whoever ordered this test was probably worried that something sinister or nefarious was happening, and the scans I think have done a pretty good job in sort of putting those issues to rest, and I'm happy about that. But the question then is, this patient is suffering from headaches. What could be causing the headaches? And there's headache disorders is a broad spectrum, but I think common things being common, and if these have not been addressed yet, I think they should be investigated. So number one, migraine disorders. Now, migraine disorders, and especially migraine headaches, are classically one-sided headaches that are pounding and give you some nausea and vomiting, and can last, even all day as this patient is happening. But they can also be on both sides too. It doesn't mean that they're always on one side. So having maybe their doctor investigate the possibility of migraines, and migraines, are not something that you've had all your life. They can develop later in life too. And it's something that can be managed easily with lifestyle changes, such as being on a good sleep schedule and avoiding certain foods that can trigger it, like caffeines and such, and cured cheeses and meats. Or even medication can really effectively treat migraines as well. The other thing that I sometimes see patients come in with headaches that are unexplained in the morning is, we kind of touched on this previously before, but sleep apnea. Sleep apnea is underrecognized and can definitely give you headaches in the morning. And you can imagine why, because a person who has sleep apnea throughout the night, their upper airway is essentially collapsing repetitively throughout the night, and their body is forcing them to awaken to get air. And so basically their sleep is never a refreshing experience or an easy experience. They're basically going through a battle every night, and a good part of the night their oxygen levels may be low, and so they may wake up in headaches. Their headaches may be a reflection of that.
I've also heard people clenching so much that they ended up getting pain around their ears and in their head as well from doing that. Two more questions, so I want to get them in.
Yes.
For the last few months, I've become aware of a large lump on each side of the back of my head at the hairline. They hurt if I rub them. What do you think it could be? I don't know. I mean, maybe this person has seen a doctor already, but that's all the information I have on that question.
Well, just hearing that story, right away, I don't think it's anything serious. And I'll tell you, and that's sometimes, maybe that's a lot of patients, that's a very important thing for them. They want to make sure they don't have anything serious happening. But the back of the hairline, especially if it's symmetric, it's on both sides and it feels about the same. I think big issues like cancer typically do not cause symmetry. There's usually something unusual about a cancer. It's affecting one side, not the other. It's very focal. That makes you worried. If he has lumps in the back of the head on both sides in the hairline, it could be a multitude of benign things. There could be some sort of cyst, like a skin cyst, or even a fatty collection of fat. It's called like a lipoma. Those can be there too. Sometimes in the hairline, you can have folliculitis sort of issues that cause acneiform type reactions that happen in the hairline. But it could be a broad number of things. Good place to start is, either seeing ENT doctor, dermatologist, or the primary care doctor.
This is a nice broad question. Is there anyone more prone to head and neck cancer, such as men versus women, or as you age, or race?
It is a broad question, but a good question, because I think it sort of speaks to some of the peculiarities that we see in our field. So, for example, 30 or 40 years ago, the classic patient with head and neck cancer, throat cancer, voice box cancer, oral cavity or mouth cancer, these were patients who smoked and drank alcohol excessively. And over time, the effects of smoking and alcohol on the lining of the throat add up, and they cause cancerous changes to happen, then full-blown cancer. Now, in the last 20 years, like we talked about, we see HPV-related cancers, and those are cancers that are not associated with smoking or alcohol. The thing that probably happened was that the HPV virus, which we all get exposed to at some point in our life, especially when we become sexually active, for some reason that person's immune system has not effectively eliminated that virus, and the high-risk strains of the virus have now taken hold in the back of the throat in areas called the tonsils, the tongue base, and over time then developed into a cancer. Now, so those patients we see are actually more likely to be men as opposed to women. There are other kind of cancers we see sometimes in patients from China or Southeast Asia, and that's Nasopharyngeal Cancer, and that's related to a virus called Epstein-Barr virus. And that virus, the patients become exposed to it, and their immune system do not do an effective job of clearing it, and it can cause nasopharyngeal cancer. And so there's all kinds of different sort of profiles we see of cancers, but just in one broad stroke, that's kind of how things kind of shake out.
Why was this particular specialty important to you as a doctor? What was it about this head and neck area that intrigued you?
So, good question, and I have a very unusual background, actually. So I first, when I finished medical school, I went into internal medicine, and there's not many surgeons out there who did that first. And in fact, I think people probably raise their eyebrows when they hear that I did internal medicine first, but I did, and I was interested in things like cardiology. My dad's a cardiologist, and I thought that I would go and follow into his footsteps. But as I finished med school, my training in internal medicine, I worked for a year in critical care, and I worked for a year in a small town in northern Maine as a hospitalist in a small hospital there, a town of 4,000 people. I always had an interest in patients who are a little bit who are struggling with things and who are unfortunately facing maybe some life and death issues and issues which are very serious. I feel like I can be my personality and the way that and I kind of grew up, and the things that I kind of gravitate to is I want to be a comfort to people who are going through tough challenges and hard experiences. So the head and neck cancer patient to me is that kind of patient who is facing those issues. It's truly life-changing to have head and neck cancer. You can imagine that your head and neck is the way you interface with the world. Like your face is your sort of blueprint, your ability to smell, taste, eat, talk. All these things are very important. And if you have a cancer in those areas, your life will never be the same again. So that's kind of what drew me to the head and neck cancer patient.
And there may be one more who just got a question in real quick before we let you go. I have lots of mucus in my throat. Could this be caused by my MAC lung infection?
So I think by MAC lung infection, he's referring to a type of atypical mycobacterium. Typical mycobacterium is tuberculosis, and then we have a lot of atypical mycobacteria as well. And patients who have chronic lung issues, or if their anatomy of their lungs are different for whatever reason, and sometimes their lungs may be normal, but they can get an atypical mycobacterial infection in their lungs. And if that were the case, then they may be generating more mucus in their lungs, which they then are expelling out their throat, and maybe that's what he's experiencing. But if he's not experiencing like a wet cough or the need to sort of expel mucus from his lungs, then it's probably not related to that, and may be related to other things of having too much mucus in your mouth or throat, such as postnasal drip or having reflux.
And I would be remiss if I didn't ask you something about COVID, and that
Yeah.
is, have you seen anything in your practice related to COVID? I was wondering if there are any long COVID cases where they've been having some lung or throat issues or anything like that.
Good question. And I have, so with the COVID, one thing that we've noticed with the COVID vaccinations is that patients who get the vaccine in their shoulder, as most of us are doing, we do know that some patients get swollen lymph nodes around their arm, so usually in their armpit. That's kind of what it's a known side effect of the COVID vaccination. Now, I have seen some patients who get enlarged lymph nodes kind of lower down in their neck as well. And it's only anecdotal. There's no scientific data behind this. I don't have plans to publish this at all, but I do wonder if the the upper neck as well may be giving some swollen lymph nodes there. Now, I don't say that to mean that ignore any sort of swollen lymph nodes you may have or bumps you may have in this area that you notice after your COVID vaccination, because these lymph nodes in that area could very well mean something much more serious too. So don't ignore those issues and seek out proper medical care.
And meaning they might already be irritated for some reason.
Yes, or they may be reflective of some other, disease process.
Right, right. Dr. Masroor, thank you so much for being with us today. We really appreciate your time. It's so interesting. And thank you for all you do every day, but especially over the last year plus during this really challenging time for all of us. So we appreciate it.
Thank you. Thank you for your time.
Thank you. And thanks to everyone who joined us today for Ask the Oncology Expert. We'll see you next time.
Okay, bye-bye.